I'm talking today about some of the newer drugs of abuse that you're going to be seeing out there, and kind of curious to see, since you're on the front line, what kinds of drugs your patients are telling you about. So I'm going to start with the topic of synthetic cannabinoids, which I'm sure you've heard a lot about. This is drugs like spice and K2, and I'm going to start with kind of a fun case, and then we can get into some of the more serious effects. But this happened when I was on service with toxicology, and we were called to the ED to consult on 11 hospital employees that all worked in a surgical unit. So these were like scrub techs and scrub nurses, and they were found to be acting very strangely at work and had to be relieved from their duties. Turns out that all of the 11 employees that we saw had actually eaten some brownies that were left in the break room by one of their friendly coworkers. And they started to feel strange about 30 to 60 minutes after they had eaten the brownies. And their symptoms included dizziness, some memory impairment, sluggishness. Some of them were laughing and giggling inappropriately. And some of them were having paresthesias and blurred vision. And on evaluation, about 4 of them had some mild hypertension, 2 had tachycardia, and 1 was actually complaining of chest pain. So they were evaluated in the ED, and their routine workup was negative. Their urine drug of abuse screen was negative, and chemistries, EKGs, all were normal. They all did well and were treated and released. Luckily, there was 1 brownie that was left in the break room, which was confiscated by the supervisor, and we got it analyzed by the Texas Department of Public Safety Laboratory, and they actually found a synthetic cannabinoid there. I have the structure on the right. And the story goes that the 20 or so year old son of the coworker had messed around with the brownies before she brought him in, or had helped with the preparation of the brownies. So what are these? They're herbal marijuana alternatives, known as spice, K2, K9, I'm sure you've heard the terms, and they started to be recognized in Europe since the early 2000s. And they're marketed under various names like incense or potpourri, and they're labeled as not for human consumption. And this is to try to get past the authorities and the legal aspects of distribution. What they usually contain is some sort of herb or plant material that's been adulterated with synthetic cannabinoid compounds. So usually they're sprayed. And so you can guess that trying to create an even or consistent product could be difficult. And so there's a lot of variation from packet to packet or from batch to batch in concentration. So you don't really know what you're getting. Typically, these products are smoked. They're intended to produce marijuana-like effects, but as you'll see, some of the effects or adverse events are very un-marijuana-like. And one of the other things that was important to the users is that they're not detected by your routine urine drug screens. And so people wanting to escape detection feel that's very important. The first reported synthetic cannabinoid exposure in Texas was back in 2008, and that was reported to the Texas Poison Center Network. But as you would guess, obviously these were hitting the streets well before then, and we're always a little bit late on the uptake as far as identifying it. And so this is just the tip of the iceberg. There's going to be a lot of use out there, but most people don't get into trouble. Most people don't end up calling the Poison Center. It's only those who have more serious adverse events that get reported in. So there's a lot of use going on out there that we don't know about, and we never know the denominator. So there were just 3 reported exposures in Texas in 2008, and then 2 more in 2009. And it was in 2009 that the DEA started really becoming concerned about this because of an increase in emergency department visits and calls to poison centers about adverse effects from users of these products. So serious things like hallucinations, a lot of paranoid behavior, interestingly, agitation, anxiety, vomiting, rapid heartbeat, hypertension, which you don't normally associate that much with marijuana. And so in 2010, it really picked up. There were 464 exposures then reported to just the Texas poison centers. About 3/4 were male, pretty significant percentage, less than 20, so teens, and 60% had moderate to severe symptoms. And again, remember, this is just those that get reported in. A lot of people use it and don't necessarily get into trouble. Nationwide, in the summer of 2010, there were over 1,000 cases of synthetic cannabinoid toxicity in almost all of the states. And this is the most recent data I could get for you from the Texas Poison Center Network again, and this is data from January 1st of 2010 to the end of just last month, so very recent data. And so you can see that really from 2010 usage picked up all the way into mid-2011 when the Texas ban kind of hit, and then the use dropped off a bit, sort of picked up again, and the nationwide ban was in 2012 last year, and it dropped down a bit, but you can see it's starting to pick up. And just like any other drug trend, it's going to wax and wane over time, sort of like what we saw 5 or 7 years ago with the cheese epidemic, where it just kind of came as a wave and then it dropped off, and now it's bouncing around. It's still out there in the community, but we're not seeing as much of it as before, and these fads kind of just come and go in the drug world. This is some data from the same Poison Center, the Texas Poison Center Network, showing the age distribution. And again, it's about the same, about 40% or so, less than 20 years of age, so patients that we may be dealing with in our practice, and the rest over 20. And this is the distribution, since, as you would expect, since males are the dumber half of the species, we're winning in this respect of doing more of these drugs. The route of exposure, as you would expect, mostly inhalation, but some ingestion, some combined. And these are the effects as they were documented by the poison centers. Again, remember, this is just what's called in, not from all of the users, but a lot of moderate effects, some major. So here's the problem with these products and pretty much anything else you're going to buy on the street is nobody really knows what's in it, right? You don't know what they're giving, what you're getting, and so it's very hard to track and figure out what's going on. The substrate herbs or plants are very difficult for authorities to identify, and even I've listed some of the plants that were identified in these products, and there's very little medical literature on it. And so, but it seems that most likely the herbs that have been sprayed with the product are not causing most of the symptoms. It's actually the cannabinoids. So the cannabinoids, the synthetic cannabinoids, were developed over the past 40 or 50 years in the study of cannabinoid receptors, and arose out of the study of marijuana. So people were looking at what's causing the effects of marijuana, specifically delta-9 THC or tetrahydrocannabinol, which is the naturally occurring cannabinoid, and they were looking at the actions and found a receptor that it was acting on. And so if you have a receptor in your body for something, there must be an endogenous ligand, and it was found that something called anandamide was the main endogenous cannabinoid that's produced in our body. And so there's receptors for that. And people synthesize different cannabinoids and use those for study, and also in the search for possible new therapeutic agents. So the drugs that we're seeing, the compounds in spice or K2, are synthetic cannabinoids that bind to the receptors, just like delta-9 THC, but they're structurally different, so different enough that they don't get picked up on the same screens. There's a lot of different types. The names of these different chemical groups are not important, but suffice it to say that there's been over 100 synthetic cannabinoids that have been synthesized and described. And some of the names that you'll see, like JWH, that's for one of the early investigators. And CP is for Pfizer. Pfizer was one of the companies that was looking into this. HU is for Hebrew University, where some of the early research was done. And so that's where some of the names come from. These are some representative structures. This is the endogenous ligand, anandamide, which actually, as some of you may notice, is a derivative of arachidonic acid. So it's actually synthesized in your body from arachidonic acid or membrane lipids. And this is the structure of the component in marijuana, naturally occurring. And this is one of the synthetic agents. So some kind of diverse structures. What they're doing is acting on the cannabinoid receptors, and there's two main groups of cannabinoid receptors in your body, CB1 and CB2, and these are being studied. They're all G protein coupled receptors, and actually the CB1 cannabinoid receptor is said to be the most common G protein coupled receptor in your brain, and so it's found widely throughout the CNS. And what these receptors do is they respond to your endocannabinoids, for example, anandamide, but they're also the very same receptors that delta-9 THC from marijuana binds to, and these are the same receptors that these new synthetic cannabinoids are binding to. And actually the synthetic cannabinoids bind with much greater affinity to these receptors, so they're much more potent than marijuana products. Interesting thing is that the CB1 receptors, besides being found mainly in the brain, are also found in the cardiovascular system. So the CB1 receptors are also found in the heart and the blood vessels and mediate some of the cardiac effects that we're seeing. The endocannabinoids are what's called retrograde neurotransmitters. So they're actually being released. The anandamide, for example, is being released from the postsynaptic cell. It's migrating across the synapse and then acting on receptors on the presynaptic membrane. So that's what's diagrammed here. So for example, it's a down-regulating pathway that your brain uses to modulate responses. And in this example, a neurotransmitter is released from the presynaptic terminal. It acts on the postsynaptic terminal, and one of the things that it does is causes release of your endocannabinoid. And this is occurring in your brain all the time. And that endocannabinoid acts on the cannabinoid receptor, which then turns off further release. So it's a way of regulating the response. And so you can imagine perhaps what would happen if you have a whole bunch of synthetic drug that's coming in and doing that same thing and turning off release of neurotransmitter. And so the effect that you're going to have is going to depend on which type of neurotransmitter is being released from that neuron. So, for example, some of the neurotransmitters involved are GABA and glutamate. So if you're turning off release of GABA, which is your brain's main inhibitory neurotransmitter, if you're turning that off, you're going to have more excitation, right? Whereas if you're talking about glutamate neurons, if you're turning that off, you may have more sedation and depression because you're inhibiting release of an excitatory neurotransmitter. And so if you can imagine, there's a lot of things going on with these receptors that we're not sure of, and I'm wondering if some of the newer synthetic cannabinoids may actually bind to, but have just a blocking effect. So they may just be competitive inhibitors of those receptors. But all of this is under study, and we're not sure what these drugs are doing that people are obtaining on the streets. The CB2 receptors, the synthetic cannabinoids are not thought to act as much on these, but CB2 receptors are expressed mainly on peripheral immune cells like T cells, B cells, macrophages, and so CB2 receptors are thought to modulate inflammation and immune responses. And we're not sure, obviously at this point, whether the synthetic cannabinoids will have any long-lasting effects on the immune system. And CB2 receptors are also involved in pain sensation. So take-home message is that synthetic cannabinoids are causing a lot more stimulation than what you would expect with marijuana. And so the adverse effects that we are seeing include anxiety, paranoia, agitation, tremor, even seizures have been reported with use, as well as hallucinations and frank psychosis. There is a actual physiologic withdrawal syndrome also that's been described in chronic users. And the interesting thing from the cardiovascular standpoint, there's a lot of tachycardia, hypertension, and chest pain that's been reported. And the tachycardia, it's interesting. You do see that with marijuana. So with acute marijuana use, heart rate does tend to go up. Blood pressure usually is stable, does not go up. In fact, it may go down. And there have been cases of chest pain or MI, rarely that have been reported with marijuana use, but it's hard to prove causality. With chronic marijuana use, heart rate and blood pressure tend to go down. Also interesting from the GI standpoint is that with the synthetic cannabinoids, we're seeing more nausea and vomiting. And typically you think of marijuana as being an anti-nausea agent, for example, in cancer patients. But with the synthetic cannabinoids, you have increased nausea and vomiting. And this is some data from the Texas Poison Center Network from 2010 that looked at these things and tried to compare the synthetic cannabinoids with marijuana. So these are exposure calls that come in, and often from healthcare facilities like other ERs. And you can see that there's more agitation with the synthetic cannabinoids, more hallucinations, also more tachycardia and hypertension, as well as more nausea and vomiting with the synthetic cannabinoids when you're comparing to marijuana. There was an interesting series of patients that came through Children's Hospital that was actually reported by the cardiology team and the tox team, and it involved 3 teenagers. They just, I guess by coincidence, happened to be 16-year-olds who, these were males who came in with acute chest pain after smoking, reporting to have smoked synthetic cannabinoids. Again, this is one of the problems with these, with trying to study these, is you don't necessarily always know what they took. But they came in with chest pain after having reported to have smoked spice or K2. And they actually had ST elevation MIs. They had elevated troponins, abnormal EKGs. The 2 that were studied by angiography, though, had normal coronaries, meaning this was probably more vasospasm, not a clot or a fixed lesion. And similarly, Parkland had reported a 20-year-old male with chest pain after smoking synthetic cannabinoids, and this patient also had ST elevation MI. And this is an EKG from the first patient that was reported out of Children's, and you can see elevated ST segments in the inferior and somewhat in the lateral leads. And this is a EKG from the second patient that has some ST elevation in the lateral leads, a little bit in the inferior leads as well, but more noticeable and pronounced in the lateral leads. And again, these patients significantly bumped their troponin. Another interesting report just from a couple of months ago comes from the MMWR reports. This was just from mid-February. And they reported on acute kidney injury associated with synthetic cannabinoids. That would be really unexpected. You don't think of that or associate that with marijuana, right? And so, the question is what's going on. These are 16 cases dating back to 2012, coming from different states, so not just one geographic area, but multiple states. And these patients came in with symptoms of kidney problem, nausea, vomiting, back pain, flank pain, and they had significantly elevated creatinines, also urinalysis that showed RBCs and WBCs and proteinuria. Some of them had renal biopsies that showed acute injury, interstitial nephritis, and actually 5 of the 16 were severe enough to require hemodialysis. And so It's not clear exactly what was going on, but all of these patients reported having used synthetic cannabinoids within the few days before symptoms. And it's thought that either there's some nephrotoxic contaminant that was in the product, or it may be a previously unreported complication from some new synthetic cannabinoid. And they did identify a new fluorinated synthetic cannabinoid. So the thing is that the illicit chemists are always trying to stay one step ahead of the authorities and are adding new groups and synthesizing new compounds. And so we don't know oftentimes what's being seen out on the street. So how do you diagnose this? Well, it's difficult because your standard urine drug of abuse screen does not detect these. So it does not cross-react with the delta-9 THC that you get from marijuana. So the marijuana screen doesn't show up positive because it's an immunoassay. And most of these structures are not similar enough to cross-react with the antibody. So you have to use gas chromatography mass spec or liquid chromatography mass spec techniques, and they can be detected in blood and urine samples. You can order these out of, for example, children's labs, or you can send it to a reference lab and have it. The lab that we use is called NMS, and you can look them up online. But basically, they do have some assays for some of these. The problem is they don't have assays for all of them. And so you're only going to detect the ones that they test for. And the synthetic chemists are not dummies. They can figure out which ones we're capable of detecting and then make new ones, right? So they're always trying to stay one step ahead of us. So your clinical suspicion is going to be based on a good history, and so, if your patient will divulge it. But a lot of these people are trying to cover their tracks, so they may not be giving you an accurate history, but you try to ask the right questions. You can try to confirm it with GC mass spec, but that's a send out and it takes weeks to come back, so it's not going to help you right away. There are no specific antidotes, and as you could tell from the symptoms, treatment's just going to be supportive. So we'll move on to the bath salts, which have been very popular recently and have gained a lot of media attention. Again, I'm going to refer to a case that was reported on out of our institution, and this was a 20-year-old male who had been sniffing bath salts and was running away from the police, had a big seizure. EMS was called, and he was found to be unresponsive, had a narrow complex tachycardia with a heart rate of 165, so really pretty fast heart rate. He got intubated at an outside hospital, received IV fluids, was found to be hyperthermic, and had a persistently elevated heart rate. On arrival to our institution, was even more hyperthermic, temp of 40.5, still tachycardic. BP was 140/60, and his O2 sats were low at 90%, so already developing some pulmonary edema. And even off of any type of paralytic agent, he remained unresponsive and was starting to have bleeding from the nose. So this patient really demonstrates what can happen with a bad sympathomimetic overdose. The labs looked really bad, had significant metabolic acidosis, developed coagulopathy, had rhabdomyolysis with the elevated CK, bumped the troponins, bumped the liver enzymes, and just developed a full-blown DIC type picture. Again, the urine drug of abuse screen was negative, and but this patient did very poorly. They made attempts to cool the patient and control the hyperthermia, was admitted to the ICU, became hypotensive, and eventually became anuric. Received all kinds of blood products to try to control the coagulopathy, but within an hour had coded, and after some CPR got pulses back, required a lot of pressor drips, but went on to death within 8 hours. And so this is what happens with severe agitation and severe sympathomimetic overdose. The analysis of blood samples came back showing MDPV, which is 3,4-methylene dioxypyrovalerone, one of the known components of the so-called bath salts that are on the street. At autopsy, there was also cardiac hypertrophy and thickening, indicating long-term use of stimulants, and the medical examiner agreed that the death was caused by the toxic effects of MDPV. So what are these drugs? They are so-called new designer drugs, although many of them have been around a while, but they contain synthetic cathinones. And interestingly, the parent compound cathinone has been used recreationally for centuries. And cathinone and the metabolite caffeine are amphetamine-like compounds that are found in the leaves and twigs of the khat plant. And these are chewed by many people. It's a kind of a cultural thing. I mean, we go to Starbucks, right, in the morning to get our fix. And so these are the countries where this practice is commonplace, kind of Northeast Africa and the Arabian Peninsula. And the stuff is very cheap. Usually the leaves and the stems are chewed. Sometimes it can be made into a tea. And this picture shows the plant being bundled in banana leaves to maintain moisture, because when it dries out, it loses its potency. This is the active ingredient. So first look at the structure on the left. This is amphetamine. Amphetamine is a phenylethylamine, which all of the amphetamine derivatives are. So this is your phenyl ring. Phenylethyl is the 2-carbon chain here, and the amine is the amino group. This has methyl group here. So this is the alpha carbon, and this is the beta carbon. Amphetamine got its name from the structure. So basically, the word amphetamine comes from alpha methyl, phenyl, ethyl, amine, and somebody put that all together and came up with this word. So if you look at the stuff that's in the khat plant, it's very similar structure. The difference is there's something coming off of the beta carbon here. So cathine has a hydroxyl group. Cathinone, which the bath salts are all built off of the cathinone structure, has a keto group. So these are often referred to as beta keto phenylethylamines, or you may hear the term BK phenylethylamines, and that's just for this keto group on the beta carbon. So the synthetic cathinones have just in the last few years really hit the scene and become popular. And again, similar to the synthetic cannabinoids, they're marketed under various names like bath salts, or obviously they're not really bath salts that you take a bath in, or plant food or legal highs, to try to circumvent being scrutinized by the authorities. And they're also labeled as not for human consumption to try to get around a lot of the regulatory laws. So as we mentioned, cathinone is the naturally occurring compound that's in the plant, and then the synthetic cathinones are derived from that. Meth cathinone, the structure shown on the bottom there, is a methyl derivative that is easily synthesized from ephedrine. So you can see if you just take ephedrine, it doesn't take a big chemical jump to produce the meth cathinone. Meth cathinone is very popular in Russia still, and a lot of it is synthesized there, and the potency is just like methamphetamine. Comes under the names cat, or you hear MCAT, meow meow. These are some of the street names. But basically all of the compounds you find in the bath salts are built off of this structure. So the one we heard about in the case I just presented was this one here, MDPV, which again has the phenyl. It's got that beta ketone. It's got the amino group, but the amino group is kind of incorporated into this pyrrolidine ring. It's got a longer chain coming off here, but the same basic structure is there, just like the amphetamine structure. And the thing that is interesting is it has this methylene dioxy ring here. And what does that sound like? That sounds like MDMA, right? MDMA, or ecstasy, is methylene dioxy methamphetamine. So it's basically MDMA is methamphetamine with this methylene dioxide group here, which is supposed to cause more serotonin release, and so you get more of those psychoactive effects. Initially, it was thought that the ketone group would cause less toxicity compared to an amphetamine of the same structure because of decreased lipophilicity and decreased passage through the blood-brain barrier, but it seems like this is overcome by people just taking more of it. So the toxicity, I think, is quite similar. And so you can see from methcathinone how a chemist could synthesize a whole family of drugs based on the basic structure, just adding different groups here and there, and that's really what they're doing. So a lot of these are found in bath salts. The ones that we see a lot of here are mephedrone and MDPV. Synthetic cathinones were known way back in the early 1900s, but people really never found any medical uses for them, with very few exceptions, and so they remained obscure. They were kind of rediscovered by underground chemists in the early 2000s who started to make these and sell them out on the street. And so use of it gradually increased in Europe in the mid-2000s, but the use of it really kind of exploded in 2009 and 2010, initially in the UK, then throughout the rest of Europe, and then it came across the Atlantic to Canada and the US. And so we really started seeing a lot of it in 2010 in the US. And that's about the same time it hit the streets in Dallas. And again, sold under the name bath salts, which really it's not. It's, you know, amphetamine-like drug. This is just a picture of how some of the different products look. I like the Charlie Sheen. Explains a few things, right? He's looking really bad now. And this is, again, the latest data from the Texas Poison Center Network, starting in the very beginning of 2010 until last month. And so you can see the use really went up a lot in 2010 and 2011, came down after the Texas ban, and then has been kind of bouncing around since then. Seems to have dropped off a bit, and so I think part of this is due to the legal actions, and part of it may be due to some of the media reporting on it, because there's been a lot of media reporting about adverse effects. But it's still out there. The bath salts seem to involve older patients, and it may be that younger patients are less afraid to do a synthetic cannabinoid, smoke a synthetic cannabinoid, and maybe they've also been paying attention to the horrible adverse effects that are reported in the newspapers and the television news. But it does seem to be an older group. Again, the dumber half of the species wins. And this is the route of ingestion, mostly inhalational, but there's a lot that's being ingested, and kind of a significant amount of parenteral use also. I just put some data up here on nationwide poison center calls. So 2009, it wasn't on our radar. I'm sure it was out there, but we weren't knowing about it yet. 2010 it started to pick up. 2011 seemed to be the peak, and now use seems to be going down a bit. And it may be similar, I'm not sure if it's similar to the phenomenon we saw with the cheese heroin, where maybe people were getting a little smarter about not killing themselves with it as well. That might be part of the process. This slide just kind of shows some of the routes of exposures and typical doses and onset and duration of effects. Generally, about 30 minutes to onset, and duration anywhere between a couple to 5 or 7 hours. How do they work? They cause release of catecholamines. So basically what amphetamines and the synthetic cathinones do are cause increased release of your biogenic amines, so norepinephrine, dopamine, and serotonin. They also block the transporter, so they inhibit reuptake of the same norepinephrine, dopamine, and serotonin so that they stay at the synapse longer. So not only are you releasing more, but it's staying there longer and causing more stimulation. And that's where you get all of the sympathomimetic effects, you know, your agitation, your tachycardia, your hypertension, and also the psychoactive effects. And this is just some data from the Texas Poison Center Network, again, showing a lot of hypertension, tachycardia, and agitation. What are the desired effects? Well, people take it because they want to feel euphoric, they want to have a lot of energy, heightened awareness. There's also increased sexual arousal. And so, you know, a lot of things that people are looking for in terms of feeling good. But the cathinones cause a lot of adverse events. And so there's a lot of agitation, some paranoia, insomnia, mydriasis, a lot of cardiovascular effects, tachycardia, high blood pressure, chest pain. What you hear about in the news is sort of the bizarre behavior, excessive physical strength, aggression, psychotic behavior, self-mutilation. It's been associated with suicidal attempts. But I think that it's really no different than what we see with amphetamines. I mean, we see all of this with meth. It's just been sort of sensationalized in the media recently as being associated with the bath salts. But honestly, we've seen this all before. The severe or lethal effects are severe agitation. There's been serotonin syndrome associated with these and as a cause of death. SIADH occurs just like with ecstasy, resulting in hyponatremia and seizures. With anything that causes severe agitation, including cocaine or amphetamines, you're going to get hyperthermia, you're going to get rhabdomyolysis, renal failure, DIC, myocardial infarction, strokes, and so forth, ultimately causing death, like the case we presented to open. Diagnosis, again, your standard urine drug screen is not going to pick it up. However, you can send it out. Similarly to NMS Labs has a synthetic cathinone assay. But the problem is, just like with the synthetic cannabinoids, unfortunately, it doesn't pick up all of them. And the chemists out there are always trying to devise new compounds with slight changes that are not going to be picked up by our assays. And the other thing that's a problem too is having pure standards for internal controls to compare, you know, your given sample against. So it's a moving target, and these are difficult to detect. But it's a send out that doesn't come back right away. So again, you have to have a clinical suspicion, and you have to identify the sympathomimetic toxidrome. So if your patient comes in agitated, tachycardic, hypertensive, and so forth, you're going to know it's some kind of stimulant. But clinically, you probably can't differentiate whether it's bath salts, your cathinones, from regular old methamphetamine or ecstasy or cocaine. They all look the same. There's no specific antidote, so it's just supportive care. And the recommendations we have now are based on our prior experience with cocaine and methamphetamine and other amphetamines, which is basically you have to be very aggressive about sedation, often with huge doses of benzodiazepines initially. So patient comes in wildly agitated, you're probably going to have to physically restrain them first before you can get IM or IV benzodiazepines on board. Sometimes these patients require huge amounts of Valium, like 10 milligrams at a time. Doses of 100 milligrams in the first half an hour are not rare, and to get them under control. And obviously, if you're at that point, you're probably going to have to use neuromuscular blockade and paralyze them. But hyperthermia is a medical emergency because those are the patients that go on to kidney failure, rhabdo, multi-organ failure. So you have to get the temperature under control as quickly as possible. Severe hypertension is difficult to deal with. If they're moderate or mild, we can usually control heart rate and blood pressure with benzos, because once you get the agitation under control, the other vital signs get better. But severe hypertension may have to be treated with vasodilators, something you can titrate like nipride or nitroglycerin, sometimes an alpha blocker like phentolamine. We try to avoid beta blockers because use of beta blockers alone, although it's tempting because your patient's agitated and tachycardic and hypertensive, beta blockers alone sometimes actually make the blood pressure worse because they block the beta effects, and then the alpha effects become unopposed, and so the vasoconstriction and hypertension are actually worse. And we've seen patients jump from, blood pressures of, 160 over 100 to 220 over 120 or something like that. So you can make it worse with beta blockers. As far as disposition, symptomatic patients, the mild patients we can monitor until they get better and do a psychosocial evaluation for all of these patients, and sometimes they can be discharged from the ED. However, patients with significant and persistent symptoms are going to need to be admitted to the hospital for monitoring. We do testing which includes cardiac monitoring, EKGs, frequent vital signs, and just the sorts of things you would expect. Chemistries for electrolytes, liver and renal function tests, CPK, cardiac enzymes, and of course we're also looking for co-ingestants and adulterants. Patients with severe symptoms are going to have to be admitted to the ICU. And that's pretty much all I have. I'll take some questions. Doing nothing has never been so amazing, but also it's not all fun and games. We have a lot of life-threatening events, so it might not be as fun a trip as you had anticipated.